Well, there are a lot of conversations around COVID right now, and with the aim of constantly clearing up as many doubts as we can, I'm in conversation right now with Dr. Shruti Tandan, who is a consultant of critical care at Jaslok Hospital in Mumbai. She's been kind enough to give us some time this evening and answer some of those questions. So you're watching this conversation on Boom Live, on all of the Boom Live handles, which means you can leave us some questions at the bottom of this conversation. We'll take it up in the next conversation we have. But Dr. Tandan, good evening, and thank you so much for giving me your time. I know that you're very busy, but there are so many questions that need to be asked at this point. My first question to you, getting straight to it, is we've now been in lockdown for 2 weeks or 14 days. Are you seeing fewer cases come in? Is this that tipping point where now we'll see the transmission drop from person to person?
So it's not that we are seeing fewer cases. So this disease is so transmissible that yes, I could say that we are seeing fewer cases than we would have seen had we not had this lockdown. But to say that I'm seeing fewer cases than 14 days is epidemiologically incorrect information. So put it in a layman's words, the disease literally spreads like wildfire. So you would have everybody who's within a certain distance of an infected individual, or he's contracted a surface, to get the disease in no time. So yes, the lockdown has helped to reduce these numbers. I'm not saying that a 14-day lockdown though is enough, because we are seeing an increase in the number of cases.
Right. There has been a lot of talk about how our healthcare professionals are staying safe. We've seen a couple of hospitals where doctors have had to write letters asking for the PPE kits. The government of Delhi has actually turned around and said it's not a question of not having enough intent or money, there just aren't enough kits to buy. Could you tell us right now how doctors are keeping themselves safe?
Okay, so the hospital that I work, we have been gearing up for this situation for some time, and I am proud to say that yes, we have enough of personal protective equipment kits. It's important for people also to understand that there are several levels of PPE. So when we talk about PPE, what comes to mind is this astronaut kind of suit. As one of the lay people once asked me, do you also look like somebody in space?
Yes.
But that is level 3 PPE, which is something when you deal with patients in the intensive care unit, because there would be a lot of contamination of surfaces, there will be a lot of aerosol generation by the procedures that we do in the ICU on patients. However, a stable COVID patient, really the PPE that you need is a 2-ply surgical mask. For some reason going to contact the patient, and there's going to be nebulization therapy, which is again something that we've actually stopped giving nebulization all across Jaslok. Even in our general ICU, we've told the nurses to stick to universal precautions and take the nebulizer in the form of a metered dose inhaler, the good old pump. Yes. Because when you nebulize patients, you generate aerosols. So if you're going to be exposed to that kind of therapy, then even with the normal COVID patient who's otherwise stable but maybe asthmatic for other reasons, you need a net. The is actually a 2-ply surgical mask, maybe with a healthcare worker wearing gloves. And I'm saying with a healthcare worker because routine population, the hand hygiene actually goes down when they wear gloves, because it's a false sense of security. So, use the gloves as a second pair of hands, but remember that second pair also needs to be washed, just like the first pair. That's something that healthcare workers remember. For example, when I round in the COVID unit, I'm using hand rub over my gloves time and again, and often wearing multiple layers of gloves. So I don't transmit infections from surface to surface. So, the argument is all patients there may be infected, but I would rather minimize the contamination of surfaces.
Doc, there was this study that was put out by the WHO about, and you mentioned it, the virus being aerosoled and then being a risk to healthcare professionals. I know a lot of people got worried that this means that it's airborne and we should worry about actually breathing it in. But would you explain to my audience what you mean? Under what circumstances does this get aerosoled? Because the only interaction we have with that, with familiarity we have with that word, is when we have it in deodorant cans. But how does this happen inside of a hospital?
No, so I'm really happy that you brought this up. So I want to clarify a lot of points. So the novel coronavirus is a droplet-borne infection. So droplets, as you know, are sizable particles. You can actually see a drop of rain. Similarly, you can see a droplet of the infection. It's something when you sneeze or you cough, you generate droplets. And as you know, you cannot sneeze or cough to a distance longer than 6 feet or 1.5 meters in this case. So most of the times maintaining that distance is sufficient, and even within that distance to wear a 2-ply surgical mask, ultimately the infection is going to get in through your respiratory passages. You know, when we talk about washing your hands, it's because we don't realize how often we touch our face with our fingers. And if we have virus which is alive on our fingers, that virus will enter through the nasopharyngeal route and infect us. That's the idea of washing the hands. And when we talk about droplet infection, that's just as far as it gets. Now, I know that I keep saying this again and again. Unfortunately, social media is playing a very negative role. There's a lot of WhatsApp forwards, a lot of panic messaging which is happening. And I did go through this study, which, you know, was labeled saying WHO has said it's aerosol spread. It's by one of the popular news channels. When you open that particular WhatsApp forward, there is no evidence, no literature quoted in it. All that it says in one sentence somewhere is that aerosolizing procedures can make the virus aerosol spread. So when we do procedures in the ICU, like putting a patient on a ventilator, that is intubation, suctioning the airway, because of the force of the air generated, or nebulization, as I mentioned, this droplet gets broken up into tiny particles. Because they are tinier particles, obviously they're lighter and they can travel larger distances, which makes it aerosol borne in those special circumstances. The virus has not become aerosol borne, and it has always been aerosol borne in these settings, which is why in the intensive care settings or in the ward where you're going to nebulize or maybe suction, you will need an N95, and everywhere else you need droplet precautions.
I don't understand. So what kind of precautions are being taken by the health? Doctors actually not when they intubate, because that's where the risk of getting infection is. Do you have access to all of that, to the understanding that's coming in from, say, China, from the West? Does that put you and your colleagues in a better position? Because the learning curve has already happened elsewhere.
Yes, so there are a lot of lessons learned from the data that's already there. And traditionally, when we do put a patient on ventilator, you do bend down over the patient to have a look into his airway so that you can identify the area which actually goes into his lungs vis-a-vis the area which goes into the stomach. Because when you need to put a patient on ventilator, you need to put a tube into the lungs. And that vision needs you to bend down to get a good angle. There is also something called a video laryngoscope, which allows you to have this vision because it's L-shaped. It allows you to have this vision even in the erect position. And that's what they're recommending. All units may not have a video laryngoscope, but if you don't have a video laryngoscope and you take adequate precautions, like what we have is a full face visor. So it's like a headband, and it has a transparent screen which covers the entire face. This is in addition to the goggles and the N95 mask. We use that when we intubate patients. Okay, India is also the land of, as we say colloquially in Mumbai, Jugaad. So we've had a lot of local people who have indigenously come up and designed these visors for us, done 3D printing, put transparency films. People have put thick films of plastic, and we've got these procured for as little as 100 to 150 rupees a piece. So it's literally a throwaway price, and that protects you. Whereas a video laryngoscope costs you somewhere between 8 to 10,000 or more.
Well, I do want to ask you, if I may, about a couple of things about treatment. You did say, of course, you do rounds in the COVID ward. There is a general sort of assumption that this virus hits older people harder and young people are generally okay. But again, news that's coming in from the West right now is that it is claiming very young lives as well. What is your understanding or your experience so far?
So really, it's the percentage of people. If you have 100 older people, you would have 20 of them who have a severe form of the disease, vis-a-vis a younger person, where out of 20, maybe out of 100, maybe you'll have 2 or 3 who have a severe form of the disease. So in that way, it is kinder to the younger population. But that, like we say, chance has no memory. So you can't say which younger person will have a severe disease. The patient that we've discharged from Jaslok, both the patients, in fact, have been younger, with no comorbidities, no smoking history. They have been, and one of them was on ventilator. He's gone home, thankfully, has had a uneventful recovery, but yes, he was 38.
Right. You said no smoking history. Should smokers completely give up at this point, give up smoking at this point?
Yes, absolutely. Absolutely, because the risk of getting a severe disease is much higher in smokers.
And I want to ask you about the
conversation. Passive smoking now that people are indoors, locked down. For the sake of the ones around you, please do give up smoking.
Yes, please give up smoking. I also want to ask you about the treatment, the malaria tablets or the HIV medication that is now being experimented with. We also had the government of India announce that hydroxychloroquine, which I understand is used to treat malaria and rheumatoid arthritis and lupus, is being advised for healthcare professionals. Is this the treatment that's being given to patients right now in all wards?
Okay, so let me clarify that. So the HIV drugs don't work in COVID. There was some speculation on this. There is a good randomized control trial. And when I talk about randomized control trial, typically what you do is you have 30 or N patients in one arm who get the drug, N patients in the other arm who don't get the drug. And you try and compare them on their comorbidities, what illnesses they have, their age, etc., and see which group did better. So since this is a relatively new disease and it comes in a severe form, there is very little of this kind of randomized control trial. And there is a good study from France which has shown the benefit of using HCQS as therapy. Now, HCQS is different from chloroquine. It's not a malaria medicine, but as you correctly said, it's a medicine which we use for rheumatoid arthritis. There is good evidence that this drug concentrates well into the lungs. So what it does is it reduces the severity of illness in the patients, in the healthcare workers when they contract the disease. So in addition to getting the disease and being of a particular age, the viral load that you're exposed with also determines the severity of the disease. So healthcare workers would be working in a surrounding, like for example, when I round in the COVID ICU, I'm surrounded by COVID patients. So the amount of viral load that I am subjected to vis-a-vis a person in the general population is about maybe N number of times, N being the number of patients I'm seeing. So it's important to protect a healthcare worker from the severity of the disease. Now, having said that, it does not protect you from getting COVID. Okay, you would still get COVID, but you would maybe get a less severe form of the disease. I also want to put a word of caution here that HCQS can cause cardiac arrhythmias. And as a healthcare worker, my risk of contacting COVID is much higher than my risk of getting a cardiac arrhythmia with HCQS. So I am willing to take that risk and take the drug. But I would not advise this to the general population where the risk of getting a severe form of COVID is much, much smaller than the risk of getting the cardiac arrhythmia. So please don't pop in those tablets.
Right. So there is this tendency we've seen actually around the world that every time a particular drug has been mentioned, it disappears from the shelf because people just go out and buy it. So your recommendation is do not take this unless you've been advised by a medical professional. But if I heard you correctly, you're saying healthcare professionals are risking cardiac arrhythmia at this point with this drug?
Yes, it's a small risk. It's not a huge risk. It's not that, I'm getting my ECG monitored every day. But yes, there is a small but definite risk. That risk outweighs the benefit of taking the drug for me. So yes, I am taking it. And just since you put in novel therapies, there's also a lot of interest now in a drug called Ivermectin, which again is an anti-parasite medicine. But like I said, there is not very strong evidence emerging. So none of this has come into the recommendations. The population I am looking after, since I'm in critical care, is the severely ill or the critical patients of COVID. And there the management does not rest on therapy, but largely on supportive care. So I have said this before in another chat, and I'm happy to do these sessions because I think there's a lot of fear and there's a lot of incorrect knowledge going out. So typically, what is supportive care? You have a patient who's had a fracture. You don't need to do much, just put him in a cast and the bone self-heals. The ventilator is like a plaster cast. So I typically put these patients on a ventilator, give the lung rest and allow it to heal. Of course, this requires a lot of monitoring also, because sometimes these patients get cardiac arrhythmias. So looking after this, taking minute to minute decisions, and this kind of supportive care is the mainstay of therapy that we're providing. The viremia gets cleared by the body's defense mechanism, but before we develop our own antibodies to it. That means as a patient develops the own antibodies, you should not lose the battle against COVID. So that's what we are doing. We're supporting you in that phase till you start clearing the virus.
And doctor, right now, if someone feels for some reason that they have symptoms, could they just come straight to Jaslok Hospital? Do they need to go to the government testing and then be routed to the private healthcare? How does it work right now?
So right now, see, the BMC has come up with a provision that they have now triaged stable patients to go into facilities such as Seven Hills, Saifi Hospital, and places like Jaslok have been asked to take over the critically ill patients. So it's not that if you come to Jaslok, you would not be taken in, and it's not that you have to go to Kasturba like before, but being COVID positive, you can be directed or you can go to any of these centers. It's not that you have to come in through government hospital. Also, at present, Jaslok is not taking admissions, and there's a lot of this in the news. So I may as well take a minute in clarifying that. We had a patient. So while we've been looking after COVID patients and discharging them successfully, unfortunately, we had a patient who was admitted with us about 2 weeks ago who came in with non-COVID symptoms. So he came in for some renal complaints, and 10 days later, I'm guessing that he was incubating when he came in, he developed fever. We investigated him and found him to have COVID. Now, this is a situation which we are going to see more and more often. Because of that, a lot of our staff was unknowingly exposed to him. Our staff has been under quarantine, so we are not equipped to handle big numbers, which is why we have stopped our emergency admissions, and we are trying to look after these patients first, clear off this quarantine period, get our full strength back, and then reopen admissions. But I'm also giving you this example because this is a situation which is going to happen increasingly now. It's bound to happen. The disease is, the adage, love is in the air. So I'm sorry to say it, but right now, corona is in the air. So we are probably exposed to it more than we can imagine. So even the WHO has now changed its recommendation, and that's not because they were wrong with what they said previously, but it's because this is a dynamic disease. So the WHO, which said that you don't need 2-ply surgical masks, is now telling you when you step out, wear a 2-ply surgical mask. When you do your essentials, come home, scrub your hands with soap and water for at least 60 seconds. And that's very important. When you touch a surface that you're uncertain about, go to the wash basin and give yourself a nice scrub.
I also want to ask you how many patients do you have right now in your COVID critical care ICU in Jaslok?
I'm not sure if I'm allowed to disclose that information. Yeah, but we are full.
You're full. All right. So the other question that does pop up for people who have other ailments or might have other emergencies, how often do you recommend that they just speak to their doctors over the phone or use a tele service to sort of, interact with the doctor rather than going into hospitals or going into the emergency rooms of hospitals, right?
Yes, as much as possible, I would encourage that. So even when we would restart, so at some point of time, the healthcare services will have to resume some kind of outpatient work. And what we recommend is that wherever possible, even when the hospitals open up to routine care or outpatient care, the hospitals are going to have facilities for telemedicine consultations. Please use those, and only if your doctor feels the need that they need to see you or examine you. And remember, when the doctor is calling you for this, the doctor is also putting their own selves at risk, because every patient now is universal precautions. He is positive unless proved otherwise. So if the doctor feels you need to be examined, we'll call you and we'll have a look, but otherwise try and do it on the telephone. So there are branches like dermatology, rheumatology, maybe endocrinology. Diabetes can be managed over telemedicine.
Yes. All right. Dr. Tandan, thank you so much for the work that you're doing, and for the fact that you're on the front lines, keeping us safe at home. We promise, on behalf of a very grateful country, thank you. And we'll stay home and we'll
say one thing to this grateful country.
Yes.
Remember that we're all in this together. We're going to get out of this together. But at the end of this and during this, please remember that we're all human beings. We're as vulnerable as all of you. Thank you.
Thank you, Dr. Tandan. Thank you so much.